My name is Nasim Pourghazian. I work as a technical officer in the NCD department of WHO's regional office in Cairo. And as you can see, the speakers we have with us today are Dr. Marie-Charlotte Boisseau, the technical lead on palliative care from WHO headquarters. We have Dr. Michel Daher from Lebanon, Dr. Mariam Rassouli from Iran, Dr. Sami Ayed Al-Shamari from Saudi Arabia, Dr. Asma El-Azhari from Morocco, and Dr. Ibtihal Fadel from the NCD Alliance for the region. My colleague, Dr. Slim Salama, will be moderating the discussion after we've enjoyed the presentations. And I would like to, first of all, thank all of you for joining. It's great to know that we have a good network of palliative care professionals, but also supporters in the region. We had a very good start on Saturday morning with the first part of the webinar, and we look forward to more people joining today so we can continue that dialogue that we initiated. I would also like to thank Sanad for the collaboration and preparations, and also during these webinars. It's been great to work with you. And thank you also for all the distinguished speakers that have accepted our invitation, both the speakers on Saturday and the ones that are with us today. I would also like to thank Ms. Rana Hanafi, program assistant in our unit, who has been fantastic and instrumental in preparing these webinars. So I will be just going through, I will be giving a brief recap of what we discussed on Saturday, and I'll try to keep it short so we really use the time effective and try to finish the presentations by 5 or slightly after 5 and move to the discussions. Is there any comment or questions before we start? Otherwise, I go.
No, I will just inform, the colleagues that we have muted the microphone just to avoid interference during the presentation, and we will unmute the presenters as we go. And please use the chat meanwhile to pose any question, and we will take it from there. Thank you very much.
Exactly, and please use the raise hand function if you have difficulties speaking. And for the speakers, you can prepare your presentations as we will allow you to share your own screen as we move. So I just want to start off by giving a snapshot of the COVID situation, just like we did on Saturday. Although it's only 2 days after, we already have more than 1,500 more deaths in the region. As of the 26th of July, we had more than 1,479,000 confirmed cases and almost 38,000 deaths. The highest numbers of confirmed cases and deaths are in Iran, Saudi Arabia, and Pakistan. And as you can see in the table where it shows the daily cases confirmed in the region, we are really in the midst of the pandemic response still. I just want to mention that the NCD Global Department, HQ and regions collaborated to do a global rapid assessment to see how the disruption of NCD services was. And this was carried out in May 2020. And from our region, we had an 80% response rate, which was fantastic. What we could see is, and I'm sure you know it better than us, is the severe disruption of essential health services due to the closure of both in and outpatient facilities, but also insufficient staff, beds, protective equipment, and stock out of essential medicines, medical supplies, and technology. And in this rapid assessment, some of the main mitigation measures that were seen in the region was triaging to identify priority, to find new supply chains, and to dispense new ways of dispensing medicines, but also telemedicine, which we will come to later on in our discussions. So I would like to just recap the first part of the webinar that was held on Saturday for those who could not be with us. We briefly spoke about the global resolution on palliative care, which my colleague, Dr. Marie-Charlotte, will get into more detail on later. We spoke of the fact that access to palliative care remains a major challenge in the region. An estimation from the Global Palliative Atlas in 2014 showed that about 5% of adults who are in need of palliative care in the region actually receive it. Regionally speaking, from a policy context, palliative care is reflected in the Regional Framework for Action on Cancer Prevention and Control. This is a framework that has been endorsed by all member states of the region. So it's something that we can hold countries accountable for and follow up on. I would also like to mention that in September 2019, a regional palliative care expert network was established to provide technical expertise and guidance to the regional office and the work on palliative care. Other than serving as for technical advice, the network is also a platform for exchange and collaboration, and these webinars are really an extension and another way of collaborating in the region. The network has developed a regional roadmap for the coming 2 years, and it has they're working on a set of deliverables across the 3 domains of policy, human resources, and service delivery. I just want to briefly mention that at the very start of the pandemic, a global working group on COVID-19 and NCDs was established at WHO with a set of objectives to enhance the global understanding between the intersection of COVID-19 and NCDs, but also strengthen coordination, communication, and provide technical expertise and guidance to member states. The main aims are to align normative work and country support across the 3 levels of WHO, and it resulted in 8 sub-working groups that are divided in the areas you can see in the below rectangles. I just want to highlight briefly that 6 out of these 8 are directly or indirectly relevant to the work of palliative care, and the outcomes of this group might be useful for palliative care policy in the region and beyond. So on Saturday, we had 6 presentations given, and we heard about country experiences, among others. Although we started with a presentation by Dr. Saba Boufred from King's College, who shared with us the preliminary findings of an ongoing cross-sectional study on preparedness to face the COVID-19 pandemic in hospices and palliative care services in the Middle East region. Dr. Pamela Farah gave us some insight on the clinical work and COVID-19 adaptations of a home hospice organization in Lebanon. Dr. Amina Al-Ansari shared her experiences on the pandemic response adaptations and also how they work at a hospital-based palliative care unit in Kuwait. Dr. Nahla Gaffer, although she couldn't be with us in person, shared her voice and presentation on her experiences from a hospital-based model in Sudan and how they provide palliative care in a resource-limited setting during the pandemic lockdown. We also had a presentation from Pakistan and our colleague, Dr. Mohammed Atif Waqar, who shared their experiences from the Aga Khan University, how they've embraced technology and found new ways to collaborate with the emergency department to fast-track palliative care patients, but also their capacity building and so on. Last but not least, we got an outside perspective from the UK, where Mr. Claude Chidiac from Hamilton University shared with us the results from a retrospective service evaluation to understand the impact of COVID-19. Some of the main topics that were discussed during Saturday's webinar were different ways to fast track and access palliative care patients in the context of COVID-19. For example, home-based screening and using palliative care nurses to test patients so that they do not have to go through the ER. We spoke about the effects of the pandemic on hospital-based versus community and home-based palliative care, the increased need and load and sometimes difficulty to provide home-based palliative care. Capacity building of palliative care teams and non-palliative care professionals, the importance to meet the palliative cares for COVID-19 patients and really building capacity both within and beyond palliative care units. The expanded use of telehealth in palliative care services, factors of accessibility, legal requirements, security and confidentiality, and necessary policies to fully integrate into the healthcare system. We spoke of the access to essential medicines, the shortages during the pandemic versus the necessary policy change for opioid prescription in general and the difficulties that we face in many countries of the region. We also spoke of change of DNR policy during COVID-19, where we heard our colleague from Jordan giving example of this, and also how we better document the experiences, both during COVID-19, but also in general in palliative care, to better inform policy as we move ahead. So some opportunities that we see with this webinar and this exchange of information is that we can highlight the importance of palliative care services and foster exchange and how we best build capacity, increase awareness and understanding of palliative care, both among clinical colleagues, but also the public. Identify and share our knowledge about advocacy and fundraising opportunities. Identify and creating governance space for palliative care at national level, which will be an emphasis on during today's webinar, of course. Strengthening integration of palliative care services at all levels of the healthcare system, and how we integrate palliative care in future national pandemic preparedness and response plans so we don't find ourselves in the same situation in the future. And as mentioned, how do we document this experience easily, and how do we translate it into policy action? Thank you, and without further ado, I would like to ask my colleague Marie-Charlotte to share her screen and give her presentation. We will have time for Q&A in the middle.
Thank you, Nasim, and good afternoon to everybody. I'm actually delighted to be with you today. Actually, it's a great opportunity and very timely. So I want to thank Sanad and my colleagues from the EMRO office for this great opportunity. I'm not trying to share my screen, so please let me know if you can see it.
Yes, we can see it, Marie-Charlotte. You just need to increase, perhaps, yeah, and that's it.
So, as Nasim already mentioned, I work in a department called Integrated Health Services in WHO headquarters, and our particular concern is to make sure that we have integrated and people-centered health services. I often say that the best example is actually the strengthening of palliative care programs, which, as you very well know, have to be integrated at the different levels of care, and also across disease groups, non-communicable disease, of course, but not only, also communicable diseases, and for all age groups. As you very well know, we use the WHO definition, which is also very broad, to define palliative care as this approach to improve the quality of life of patients and their family. And this includes obviously pain control, but not only, all sorts of suffering, including psychological and spiritual suffering are also included. A key component of this approach is obviously the early identification of patients who would need palliative care. So it's definitely not limited to end-of-life care, even if obviously we understand that palliative care include end-of-life, but it has to be planned very much in advance. I'm sure you are all convinced of this, but it's sometimes still difficult to convince others, sometimes also policymakers, about the real meaning of this approach. So as Nasim mentioned earlier, the mandate on palliative care was given to the organization by the adoption of the World Health Assembly resolution in 2014, which is actually a very good document in terms of insisting on this holistic approach and comprehensive approach of palliative care. Now, what I would like to do in this brief introduction is to spend a couple of minutes on the reason why, the fundamental reasons why we have to strengthen palliative care in all sorts of settings. And this is due to an ethical duty, the ethical responsibility of non-abandonment. This responsibility, as you very well know, is, of course, a responsibility for professionals, healthcare professionals, but it's also a responsibility for policymakers and health system to ensure that the conditions are in place so this duty of care is possible in practice. We have seen in the context of the COVID-19 that it is sometimes extremely difficult because of the emergency, and we will come back to this issue in a minute, also on the fact that health systems are suffering disruption. It is always very difficult to keep the continuity of care, and I think we have to remind this ethical duty to everybody, so at the end, people in need of palliative care can access to it in concrete in this situation. Many patients are in need when they are suffering respiratory failure, and in particular, ventilation has to be withdrawn. So there is a chain between the different levels of responsibilities. Abandonment of patients by clinicians has been identified as an act of torture. So it's definitely a huge responsibility. But there is a linkage with existing national policies and the real preparedness of health system to allow professionals to provide this kind of care. So as I mentioned, one of the big challenges we are facing in this crisis is the disruption of health services, including in high-income countries, and the fact that human resources, infrastructures, financial resources, so the whole health sector is lacking coordination and is focused on the response to the pandemic with a high risk of delay for other interventions in general, but in particular for palliative care. So I want to refer here to an important document that was published a couple of weeks ago to insist on the need to maintain essential services. This is really an initiative from many departments and different regions across the organization. And it's probably quite important for countries to look at these guidance in order to face the current challenges. In a context like this one, it's also extremely difficult for health professionals to make decisions because it's difficult to establish priorities, and there is definitely a need to be prepared in advance and also to learn from experiences, because it's not the kind of skills you can just have in front of an emergency. So in the context of COVID-19, for example, it is extremely important for clinicians to identify all patients that could need palliative care in advance and prepare advanced care plans. It is obviously necessary to discuss this not only with the patients when possible, but also with the family members and all caregivers, and to document what are the goals of care. I have to mention also another important document that was one of the main references in the context of the COVID-19 crisis. This document is part of a series of guides which was published since the adoption of the resolution on palliative care. And one of these guides is actually focused on how to integrate palliative care and symptom relief in this kind of context of humanitarian emergencies and crisis. I know that Eric is with us this afternoon. He has been one of the main authors of this document, and I think it's an important reference for you also to be adapted in the current situation. So based on this guide, we included in the interim guidance for the clinical management of COVID-19 patients, we included a brief section on palliative care to raise attention on the need to ensure access to palliative care and also to develop these plans, as I mentioned earlier. One of the elements in this section on palliative care we recently developed for the COVID-19 crisis is access to opioids. I know this is still an important barrier in many countries to access palliative care, and even worse in the situation of a crisis such as the one we are facing. So it's important to consider the possibility to use opioids and to do it in a way that is clearly defined by the local guidance also, and sometimes institutional standards. So professionals have a clear framework to prescribe this kind of drugs. I will not go into details in this section. It's just to mention that we have also developed some training tools that are available in several languages, I think now, linked to the interim guidance on clinical management of patients with COVID-19. So you have some basic knowledge that can be useful for a clinician who are not specialists of palliative care in providing this kind of care to patients. Actually, who can provide palliative care? This is often a question, and I think we have to be clear that even if we need specialists of palliative care, we also need people with less knowledge, less specific knowledge in palliative care, but trained in a way that they can provide a palliative care when needed, where needed, and this is important in different kind of setting, including primary healthcare level and even home-based care. So it's very important to also have this kind of basic training available. I want to share with you another important work we are currently doing also with some colleagues who are part of this seminar in order to strengthen palliative care services and to strengthen the preparation in delivering palliative care, even in crises such as the one we are facing. One key aspect is the need to measure what we are doing in palliative care programs. And this has been identified as one of the priority of work for the organization this year and next year. So we started the development of palliative care indicators with a group of experts. And actually, I like to use this slide because obviously we have a group of international experts who can provide some a level of consensus on what would be hopefully a small set of indicators to be used everywhere. But we cannot forget that we have to adapt, and building a palliative care program is like building a house. You have to be very well aware of the setting, including the cultural setting where this is going to be done. And this is why we are particularly happy to do this work also with our colleagues from EMRO and with the regional network who is actually conducting a survey to be sure that what is proposed at global level makes sense, actually is relevant to the diverse situation in your region and also in other regions. For us, it's particularly important to have this set of indicators so we can also have a level approach and evaluate progresses in the different countries. I wanted to come back also to one of the points you discussed last Saturday, because in this crisis, but not only in this crisis, we have more and more feedback on the relevance of innovative approaches, such as the use of new technologies, well, telemedicine, teleconsultation, and even very simple tools such as mobile applications. So we did a study a couple of years ago also on the use of a mobile application for family caregivers who were able to have some basic information on providing palliative care at home, but also using this tool, they were able to communicate with the palliative care team. And I think it's definitely something we should discuss to improve the quality of palliative care, in particular in this context of home-based care. I want to end this introduction coming back to two important documents, which are actually confirming the mandate of the organization regarding palliative care. This is the Astana Declaration. As you know, this is a document focusing on primary health care. It was adopted 2 years ago, and it's clear that palliative care is part of this approach also. So if we really want to have integrated palliative care programs, we should go through this entry point of primary health care. And the second document is the political declaration of the high-level meeting on UHC from last year, which is also insisting on the inclusion of palliative care in the strengthening of UHC across the globe. So we definitely have a strong mandate, and we are currently in a situation which is convening once more our ethical responsibility to strengthen programs and to provide better quality of palliative care. So I will be delighted to discuss with you, also to hear from you, your experience in your different countries and what can be shared, maybe also at global level as lessons learned. Thank you.
Thank you very much, Marie-Charlotte. Thank you also for finishing with these important declaration and really highlighting the importance of UHC as an entry point for palliative care as well. In the interest of time, we'll move straight to the next speaker, which is Dr. Michel Daher. He is part of the National Committee for Pain Relief and Palliative Care in the Ministry of Public Health in Lebanon. Lebanon has done some great progress when it comes to palliative care policy, and we're very happy to hear about your experience and country example. So would you like to put up your presentation, or you prefer us to do it from our end?
Hello, everybody. It's great having you all this morning, and thank you WHO and Sanad for the opportunity. And I'm pleased to be just talking after Marie-Charlotte, who had an excellent introduction to the session. I start my topic by the palliative care and COVID-19 challenges and opportunities by a reminder that healthcare is a human right. And of course, people, every person who will need palliative care will have access to these services. States and countries must ensure that people enjoy that right. And finally, the national health system should include palliative care program. Our policy at the national level is that patients' referral to palliative care team will be for several reasons: symptoms control and psychological and spiritual needs, and of course, end-of-life planning and support. When to consult palliative care team? Every time we have a disease, a life-threatening disease, we should start from the beginning a diagnosis to consult palliative care team and continue along the progression of the disease from diagnosis to end of life. We insist on the multidisciplinarity and the interdisciplinarity of the team, which include several specialists from physicians, nurses, pain management, psychiatrists, social worker, and of course, pharmacists and physiotherapists and other, depending of the case. Reaching this policy was not a rapid process. It started in 2000 in Lebanon, but a good milestone, an important milestone, was in 2004, where we had deep legislative changes in the country. The law that we call the famous law of patients' rights and informed consent in 2004 have taken several ethical issues in consideration. And of course, we had a response and application about the futility of treatment, about an answer for DNR orders and how to manage with people who will need this order. And of course, the availability, affordability, and easy prescription of opioid, especially oral morphine. And most important at that time, the creation and activities of NGOs that offer home-based palliative care. And Sanad, who is promoting of this meeting with the WHO, is one of our famous and the most active one in Lebanon for the time being. And an important milestone also in Lebanon had the creation of the National Committee for Pain Relief and Palliative Care. This was in 2011 by the Ministry of Public Health, and which put the basics of the implementation, education, promotion, and development of palliative care in Lebanon. Four teams were treated and put by this national subcommittee: the education, practice, research, and policy. Here are the, if you want, the aim and the objective of this committee, which include leading palliative care professionals and representing almost or the palliative care organizations, universities, and also the Ministry of Public Health. This is a copy of the decree of the creation and the mission that was established at the Ministry of Public Health for the committee, the National Committee Palliative Care. And now we can say that the current situation and the policy that include introduction of in the pre and postdoctoral curriculum, drug availability, recognition of the new specialty with new physicians and nurses specialists that came back to Lebanon and starting their work, and effective care services in the main hospital of the country. And more recently, a new ministerial decree for palliative care services reimbursement was and it's putting how to reimburse the services of palliative care either in the hospital or in hospice or at home care. We can say that palliative care stakeholders in Lebanon are now well identified, and they are working together for the implementation and development of palliative care. The Ministry of Public Health, we have palliative care units in the main university hospitals. We have mobile units that are working with the hospitals and continuing for home care. And we have, of course, that came for home care of our patient. So, and here can which in February in Lebanon, with the palliative care challenges in response to it. There are significant new palliative care need because many COVID-19 patients and families will require it. This became a heavier charge for people who are providing palliative care services because the COVID-19 patient came and they are added to the services of palliative care. There are significant new palliative care need also for existing patients, including in communities because of travel restriction, infection risk, potential medicines stock out, and infection risk for providers and patients because lack of personal protection equipment, the famous PPE, and it is need for psychosocial and spiritual care because of separation of patients and family. There is increased difficulty in delivering such care. And finally, scarcity of resources that may lead to rationing of healthcare services and the famous triage, necessity for triage, and the ethical problem that is related to this triage. So what are the key ethical principles for optimal care during the COVID-19 pandemic? First, abandonment, and and of course Marie Charlotte started as a presentation with this. It is important that there will be a continuity of treatment of these patients. The second is the respect for persons, and of course the informed consent here is very important. We should always inform our patient and have their consent. The autonomy that should only be restricted when compelling public health reasons, because of their work. Confidentiality also must be maintained at all time, unless for some compelling public health reasons. Justice and fairness should be respected. Patients with similar health conditions have equal in discrimination. So that's why our national ethics committees, and I am at the request of the Ministry Council, has elaborated what we call now the recommendations and general guidelines for ethical healthcare decision-making.
We still do not hear you, Dr. Michel. I just leave the slide up for a minute so colleagues can read, and then I would suggest that we move on to the next presentation, because we cannot hear you. I hope we can solve this problem by the time we get to the discussion, because we're really keen to hear more about the Lebanese experience.
Okay, ma'am.
Sorry about this. And thank you also for highlighting the ethical principles. I think we often make the economic and the policy cases, but we cannot forget the ethical case for palliative care and the work that healthcare professionals do. And as I mentioned, the Lebanese experience to integrate palliative care into the Ministry of Public Health has been a really good example. So I hope we can discuss this more in the discussion, and I hope the sound will work better by then. So in the interest of time, I would like to ask Dr. Mariam Rasooli. She's part of the Ministry of Health and Medical Education in Iran, to put up your presentation and let us hear about the Iranian experience when it comes to palliative care. Over to you.
Thank you, Dr. Nassim. Hello, everybody. First of all, I would like to thank our colleagues in WHO and Senate for organizing the webinar, and it would be my honor to attend, and thanks for your invitation. I would like to talk about the response of palliative care in Iran to COVID-19. First of all, I would like to describe the PC status in Iran very briefly. As you know, NCDs are the most important cause of death in Iran. And one of the main necessities in the health system is to provide palliative care for these patients. Palliative care is a relatively new concept in Iran, and Iran is in Group 3A in terms of PC provision in the world. And as you know, in this group, palliative care is provided sporadically and is not well supported. About the history of government activities in the field of palliative care, it dates back to 2011, when the development of palliative care service package for cancer patients in Iran began, and it's still being implemented. Accordingly, an action plan has been designed for the development of palliative care in Iran, which includes components such as the development of home care services, human resources training, free or low-cost access to essential medicines, and the revision of healthcare guidelines. I would like to say that the communication between the Ministry and health services, including palliative service delivery throughout the country, is established by 64 universities of medical sciences, which are located in all provinces of the country. And it's interesting to know that Iran is one of the few countries where the Ministry of Health is responsible for providing health services as well as medical education and research. And due to its special structure and the fact that it covers the whole country, the PHC system is considered one of the most important advantages of our health system, through which many services can be provided for the entire population. Since there exists no independent and organized palliative care system in Iran, this type of care is implicitly provided for cancer patients as a part of cancer management by the Iranian health system. About essential medicine, it's a part of PHC that's distributed in the network system among people needing these drugs. Therefore, these drugs are available almost all over the country. Another advantage is the large number and the geographical distribution of home care centers across the country. And currently, there are about 400 active centers in Iran, many of which provide non-specialty PC services for patients. And considering the importance of healthcare professional training in PC provision, several informal courses are being offered in hospitals and some nursing schools. And in regard with the current situation of the country, one of the most important advantages of palliative care is the large number of researches and articles published in this field, which is especially important in the needs assessment and the development of a structure to establish a palliative care system. About the challenges, there are challenges towards the establishment of palliative care, the most important of which are the items provided in this slideshow. These challenges include the lack of a national PC program, no budget being allocated by the MOH, the lack of a clear and well-defined structure in the health system, and the lack of a position for palliative care providers. And one of the important challenges is the difficult access to opioids, which has always brought up difficulties in the country and has resulted in Iran's poor rank among the countries in the region. Although morphine is produced by several pharmaceutical companies in Iran with a quality close to international standards, patients do not have enough access to it due to the strict regulations, unfortunately. After an oncologist prescribes the drug, the patient requires to visit the treatment deputy of the related university and to obtain a permission for receiving morphine from some specific pharmacies. In order to overcome these challenges and move towards the establishment of a palliative care system, measures are being taken, including the development of an independent position for the palliative care, making efforts to obtain the insurance coverage for palliative care is very important for us and for our patients. The establishment of long-term care facilities and the establishment of a pediatric palliative care system, and efforts have been made to increase the number of in-service healthcare professional training courses. But about the COVID-19, as the second country to declare 2 COVID-19 deaths on February 18, within 50 days after China, unfortunately, Iran is still among the countries with the most cases of COVID-19 infections and deaths. And obviously, overcoming this pandemic requires specific strategies varying from country to country. As I explained before, the most important advantage of Iran's healthcare system is PHC. So we use the PHC system for screening and follow-up people, including patients who are suffering from NCDs. And also home care centers are considered as one of the advantages against the COVID-19 pandemic. However, as I said, the lack of insurance coverage of home care costs is one of the serious challenges, and it's a major obstacle in this regard. Since the beginning of COVID-19 outbreak, the provision of home care for mild COVID-19 patients with underlying diseases became very important. So service packages were developed in this regard, and the tariffs were introduced and communicated to home care centers. In addition, home care guidelines were also designed and communicated for COVID-19 patients and their families, as well as healthcare professionals. Although no guidelines were developed specifically for cancer patients, they included tips on healthcare provision for these special patients. And during the COVID-19 period, if efforts have been made at the PHC level to provide basic services to the patient and the family through education virtually. However, except in few centers across the country, literally no services are delivered under the name of palliative care at the second and third levels, and related services such as symptom management are provided in the form of routine hospital procedures. And a treatment guideline on dealing with COVID-19 has also been developed in regard with patients with cancer. And for instance, using telemedicine can be utilized to do patients' follow-ups. Furthermore, COVID-19 diagnostic protocols are developed separately for patients with cancer. As an example, lung CT scan is mandatory in cancer patients, even in the absence of respiratory symptoms. And also the development of instructions for providing mental counseling services, and its communication was one of the important actions to promote mental health in these patients. And since the outbreak of the pandemic, efforts have been made to teach the basics of dealing with COVID-19 and to raise the staff's awareness. Obviously, if a strong palliative care system existed in Iran, care services would be delivered to cancer patients in an organized way by taking into account their specific conditions. For instance, problems concerning pain management are naturally being increased during COVID-19 because many patients or their families prefer not to leave home for the fear of getting infected by the disease. Obviously, aside from all the problems it has caused, COVID-19 has created opportunities and that may move the palliative care system forward. A shift of care provision from hospitals to the community and home, and perceiving the urgency of insurance coverage for these services are among the most important achievements in this field. In addition, focusing on the organization of volunteers and the community participation in care delivery, understanding the importance of the presence of a psychologist, the utilization of telehealth during care provision and follow-ups, and the need to revise the procedures of drug prescription and distribution are among the other positive consequences of COVID-19. Ultimately, it's certain that COVID-19 pandemic will end as did all previous ones, although it obviously will not be the last. Therefore, the lessons learned from managing it in each country and sharing it with other countries can help prepare the world to deal with future pandemics. Thanks for your attention.
Thank you very much, Dr. Maya, for an interesting presentation. Thank you also for highlighting the high number of publications that you have on palliative care. And this is, of course, relevant to what we mentioned before on documenting the experiences, part of what we discussed on Saturday, and we might also have the chance to discuss sooner in our discussion. So next speaker is Dr. Sami Ayed Al-Shamari, palliative care doctor and consultant at King Fahd Medical City in Saudi Arabia. Please, over to you for your presentation on the Saudi Arabian experience.
Thank you very much. Hi, everybody. This is Dr. Sami Ayed Al-Shamari. I'm palliative care consultant working in Saudi Arabia since the last 16 years. I'm also a palliative care national lead in Ministry of Health. I'll give you a brief about what's happening for Saudi Arabia and in particular palliative care patient and family during the COVID-19. So we start, if you want to hear the story of palliative care in Saudi Arabia, it is back a long way back to 28 years in 1992 when it is started palliative care service in King Faisal Specialist Hospital, thanks for Canadian physician in that time who was initiated palliative care service. It was Dr. Black Fraser, Dr. Stuart Brown, and others. They start the backbone of palliative care service in Saudi Arabia. Since that time, the service is gradually spread through the country. It was initially in tertiary hospital, institute, and then become starting to expanding further to the Ministry of Health hospitals. And it was steady expanding until we reach September 2016. This is a very important date where the new model of care started in all Ministry of Health hospital, and luckily enough, I consider it palliative care become integral part of it. And after starting the new model of care in 2017, DNR policy was implemented on all national hospitals, although the DNR policy was implemented in late 90s in the last century, and in 2018, national palliative care guidelines initiated by expert physician, 20 physician by Saudi Health Council, and spread since that time. Also, we unified the policy and procedure in all Ministry of Health facilities. So all the policy procedure in all area, in all hospital, in primary and secondary and tertiary hospital are unified nowadays. And to implement the end of life and palliative care service in all periphery cities, we did a mass training, and we changed a little bit the concept of palliative care to be physician or nurses oriented to be a multidisciplinary team oriented. So we did a mass training for multidisciplinary team, palliative care training for whole kingdom. As you know, we divided the kingdom into 22 clusters, each cluster covering 1 to 1.5 million population. And in June 2020, there was a royal order from to declare that any patient who receive treatment on oncology or on non-cancer facility in tertiary hospital should be transferred back for their local city to get palliative care service in their hometown. In June 2020, also we luckily enough to initiate the national virtual palliative care clinic started nationwide. So this is just overview what we mean about the new model of care. In September 2016, we started designing a new model of care system for Kingdom of Saudi Arabia, where we empower the patient and their family to take control of their health and keep people health focusing on preventive approach. And we try to push the patient from the hospital to the community as much as we can. After 6 months, implementation preparation started, and we choose 5 different areas of the kingdom, where is 5 system of care were detailed by 5 national pathfinder, and cross-cutting intervention and keep keep well system of care lead were detailed by a central team. After that, in the same year, we start to implement the new pathway, and luckily enough, the Riyadh area and in C2 King Fahd Medical City, we try to test the new last phase initiative and palliative care service. After 6 months of implementation and succeed the implementation, we reached the national rollout based on the cluster and local implementation of the labor work streams. This is just to highlight the initiative for end-of-life and palliative care in whole kingdom. The initiative is divided in three initiatives. The first one is to establish centralized palliative care service in each cluster, where there will be primary, home care, secondary hospital and tertiary hospital, and all this service is one controlling under one area center of palliative care. The second initiative is to build the capacity and train the caregiver for all last phase patient to treat the patient, to push him to the community. And the final initiative to have developed 20 beds hospice for cancer patient and 20 beds for non-cancer patient in each cluster. So to make it short, we will have 44 hospice in different areas of the kingdom. This is our plan when we start to have mass training for all multidisciplinary team in the kingdom. We did the training in the waves, and as you see, there is wave 1 in 2018, and we finish it in early 2019, the second wave and the third wave. And luckily enough, we are lucky, consider ourselves in Saudi Arabia lucky, because when the COVID-19 hit us, we almost finish all the multidisciplinary training and start to practice all the activity in the kingdom, except wave 5, where is one cluster remaining, and we will reschedule it in September 2020. So regarding the education and capacity building, as you know, Saudi Arabia is one of the country in the area that have all kind of the training. We have 15 members in each multidisciplinary team training. As I mentioned for you, we did for them crash courses with 1 week interactive lecture face-to-face and 3-week clinical teaching. We managed to have 22 multidisciplinary team graduated so far. Also, we have a 3-month palliative medicine certificate for those who's non-palliative care physician, i.e. oncology or family physician, who want to have further certificate and practicing and prescribing narcotics. Also, we have 2 years palliative care fellowship program, and we have this fellowship since 2001, and in 2016 we increased the year from 1 year to be 2 years, and we just finished from accepting the new fellow in that, and we have more than 20 candidates in this year as a new palliative care fellow. A lot of undergraduate and postgraduate rotation mandatory for the student and physician, for nurses and physician. I'll give you example. We have mandatory rotation for internal medicine program, family medicine program, oncology, anesthesia, and others. Also regarding the essential access of essential medicine, we have all the type of all medication and using in palliative care service in the major hospital, and we just finished the first draft working with the expert physician in Saudi Health Council to release our essential medicine list, and we divided the medication as a mandatory list, necessary and optional list. There is one question about palliative care service as a part of national benefit package, and what is the level of care. We have it, and the level of care is in all level, from primary, home, and a secondary, tertiary hospital. This is just to give you over highlight about the new model of care. And if you see in the down here, there is 6 model of care, keep well until the last phase, palliative care. So we are integral part of the care service in Saudi Arabia, and this is the initiative. Mandatory, like patient and family support, hospice care service, multidisciplinary team, and we have 42 cohort intervention. Half of it is cross-cutting between all the sector, and we focus on health hotline service, also enhanced primary care and virtual education. As any country in this area, we hit by COVID-19, and the effect in the beginning was huge. As we see from our statistics, we have a 25 decrease in OPD visit and 13.4 decrease in prescription issue. This is comparing between 2019 and 2020 in the same months. And regarding the emergency visit for the palliative care physician, we noticed that 16.5 decrease in the palliative care to reach the emergency seeking admission because of different reason. One of it is lockdown when we have it, and there is other different issue. But once the patient reach that hospital, they are in bad shape, and usually we admit all the patient reaching the ER physician immediately. For that, 6.5 increase in emergency admission, and also 6.8% less in palliative care average length of stay, and 30% decrease in the hospice patient. Palliative care achievement, what we achieved during the COVID-19 regarding palliative care. Luckily, we completed a shifting caregiver training program from face-to-face to be online, and we launched the online program in April 17, 2020, and we finished from training 181 caregiver. Also, we activate and tracking hotline service to help community palliative patient with the 380 patient. Continue bereavement service to help patient and their family, including COVID-19 patient. And until last week, we serve 580 patient family. We have also online end-of-life dashboard updated till 2020 June, and we did a brief survey for the end-of-life team in C2 regarding what is the solution, IT solution, and how we can move forward. We contact the Ministry of Interior regarding using narcotics and sending narcotics through the mail service, and we get the permission for sending this medication, sensitive medication, to the patient through the mail. And also we continue seeing palliative patients virtually, especially for those who are in primary health care after they close some number of primary health care due to shifted the service to be screening center for COVID-19. We didn't forget the education for the multidisciplinary team for nurses, physician, and we did 3 knowledge sharing session with a good participant, and the example is like bereavement service during COVID-19, last phase hotline, and breakthrough pain management. We also observed the shock regarding the teaching the fellowship fellow, and we shift all the education activity through the Zoom, and we have increased 20% shifting the patient from the hospital to the home care service or community service. This is an example of our online caregiver training program, and with 6 modules that including different subject helping the caregiver to care for the patient end of life in the home. Also, this is the hotline service, and this is the result. I just give you some of the brief about why they calling. If you see in the left side, this is we discovered that majority of the patient calling through the hotline because they need to refill medication, and 31% of the patient asking about they have symptoms, complain, and other they want to reschedule their appointment. If you see in the middle of this screen, if the patient after the end of the calling, if they are happy, and we discover 91% of the patient they are happy, and the last statistics regarding who's calling, and we discover 50% of the calling was the son of the patient or daughter, and only 32% of the patient himself is calling. And regarding shifting the tertiary hospital from face-to-face to the virtual clinic, we succeed to shift 5 to 7% of all patients, and with 80% satisfaction rate. And this is an example from Ministry of Interior to accept sending narcotics medication or palliative care medication through the kingdom through the mail service. So what is this is the last slide, just to recap what we are planning to do after recovery from the COVID-19. We will continue to expand virtual clinic to be 30% in the end of 2020, and continue to expand in community palliative care service, especially for community hospice, primary health care, and home care service. Expanding the time for hotline service to cover 24s instead of 16 hours now, and also expanding non-cancer palliative care service to having, we have now cardiology non-cancer. We will expand for seeing patients with the nephrology, with the lung disease, with the with liver cirrhosis, neurology, etc. We will collaborate with the private sector. So far, we have 2 hospices, one in Riyadh and one in Jeddah, and we will invest more to have collaboration with the private government relationship. And last point I want to emphasize about it is training is the key for any success implementation of palliative care. So we will do more training in palliative care service in the coming days. Thank you for listening to me, and I hope to cover what is going on and the service in Saudi Arabia. Thank you very much.
Thank you very much, Dr. Sami. It's amazing to see, it's encouraging to see how many achievements you've had during this short period of the COVID-19. Thank you for giving us this comprehensive overview. We have 2 speakers left. The next speaker is Dr. Asma from Morocco, which will be our last country presentation. Asma Azhari is a palliative care doctor at the Mohammed VI Oncology Center in Casablanca. Thank you for being with us, Asma. I'll hand it over to you here now. Would you share your presentation yourself from your end? Great, thank you.
So, hello everybody, do you hear me? Yes?
Loud and clear.
Okay, thank you for the invitation. Well, in Morocco, we started to talk about palliative care in 2010 because it was for the first time in Morocco that palliative care appears to be a strategic axis within a national health plan, in this case regarding cancer, on the same level as prevention, early detection and diagnosis and treatment. The palliative care axis is the fourth strategic axis of the National Cancer Prevention and Control Plan 2010-2019, and it includes 4 actions broken down into 13 measures oriented towards the promotion of pain management and covers the needs of patients with cancer and palliative care situation. In Morocco, we have 6 units of palliative care, all of them integrated in oncology centers in 6 different cities. And all of these units of palliative care have the same operating mode. They are mixed unities of palliative care. I mean that they offer 4 types of services. All outpatient consultations for patients who are able to move around, consultation with principal caregivers and bereavement consultations, home visits for strained patients living in urban area, and hospitalization and day hospital for patients with uncontrolled and complex symptoms. And we have also a phone service available every day of the week. So in Morocco, our patients are patients with cancer and palliative or terminal situation with a Karnofsky index less than or equal to 50%. The mean of the Karnofsky index of our patients is about 40%. It means that their survival prognosis is about 3 months. And we have 3 types of patients according to their levels of complexity, minimal, medium, or maximal complexity. And the majority of our patients, more than 80%, have medium complexity because of the social components. The approach taken in general in Morocco in the field of health is that of rationalization of human resource, material resource, etc. The points that justify a new organization in palliative care based on rationalizations is the high risk of contagion of the healthcare staffs and the high risk of contagion of the patients who are immunocompromised and living in a disadvantaged social environment. But on the other hand, we know all that palliative care is a biopsychosocial and spiritual management that implies a very close relationship between the healthcare provider and the patient. So due to this limitation of resource, the patient may feel abandoned by the system, and this can expose us as healthcare providers to what we can call a situation of an emotional cleavage and a feeling of frustration. Actually, as a palliative care team, we found ourselves confronted with a real bioethical issue where we wonder if the principles of non-maleficence and beneficence are still possible. Well, I think yes, if the positive effects of the rationalizations are greater than their negative effects. That's what we call in bioethics the law of the double effect. Anyway, as palliative care teams, we tried hardly during the pandemic of COVID-19 to offer good palliative care throughout rationalized but human and coherent organization that guarantees the patient comfort and the healthcare provider comfort. So regarding the outpatient consultation, we prioritized the consultation that cannot be postponed with the patient with maximal complexity who are unstable with uncontrolled symptoms that we cannot be resolved remotely. Apart of that, the consultations were limited to the new cases referred to the unities and the consultations with the principal's caregivers. The hospitalizations were indicated when we had no alternative, only in case of an extreme indication through a short stay in a single bedroom. In this case, the administrative hospitalization protocols were made as easy as possible to avoid the comings and goings of patients and their companions as much as possible. Same thing for the day hospital. It was reserved to gestures that cannot be carried out by the caregiver at home, and when the home hospitalization is impossible to achieve because of the social context. We prioritize mostly the ACT sphincters with respiratory discomfort. For home visits, we had two scenarios. The first one is regarding the teams that can maintain the home visits, teams with the driver available, teams who work in a small urban area with a small number of patients and usually do a small number of home visits, and having in this situation of COVID-19 enough protective equipment to work safely. For them, we recommended to prioritize home visits that cannot be postponed with patients with maximal complexity, and we recommended to do only one home visit per day and one healthcare provider per home visit, because usually the doctor and the nurse go together to do the home visits. And we recommended to call the family, the patient and his family before to do the home visit and ask if there is a fever or respiratory symptoms. And in this case, to use maximal protection measures if available. And the second scenario, the sad one, and when teams cannot maintain home visits because their driver were redeployed to work and COVID-19, teams who work in very big urban area like Casablanca with a lot of patients and doing usually a lot of home visits and not having, in this situation of pandemic, enough protective equipment to work safely. For them, we recommended to strengthen telephone consultation and health education for caregiver, and to extend prescription and to give to the families a provision of the expensive equipments or equipments that are not easily accessible in pharmacies. Normally, we have more call received than call made, but in COVID-19, we recommended scheduled calls through a calendar of made phone calls in order to avoid to lose patients from the follow-up. So the call can be done by the doctor or the nurse, dependent to the needs of the patient and his family. And we established a frequency of calls according to the complexity of each patient. When the patient is stable or asymptomatic, or living in very favorable social environment. So we call him one time every 2-3 weeks. But when the patients has a medium complexity with a lot of symptoms and taking a lot of treatments or large doses of opioids or having a bed sores or tumor sores, so we call the patient and his family 1 to 3 times a week. And when the unit patient family has a very high emotional complexity, and when the patient is living his last days, so we call them every day. For opioids, we have 2 kinds of prescription terms. one for the RAMID patients. So RAMID patients is the patient who doesn't have income and can have free medical services. For this type of patient, we usually dispense opioids every 2 weeks, free or of charge in the oncology centers. And for the other patients, they usually buy the opioids through a prescription of 28 days and pharmacies that are only available in cities with oncology centers. For caregivers, we recommended to the families to have preferably 2 caregivers for the patients. One caregiver who provides directly cares to the patients, and this one must avoid as much as possible contacts and must not go to health centers. And a second one who can go to the hospitals for consultation and prescription renewal for the patient, and this one must not be in contact with the patient. And if the first caregiver has fever or respiratory symptoms, he must be replaced by another family member. And we give some recommendations to caregivers, like to strengthen hygiene measures, to use gloves for cleaning the patient, to ventilate the home, to maintain a good hydration and hygiene, to use WhatsApp video calls, and to try to transmit calm and serenity for the patient, and to seek support from the community if they need it. For us as a healthcare provider, the situation of the COVID-19 has possible psychological consequences like anxiety, depression, post-traumatic stress. However, we know that palliative care teams have a lot of strengths. The most important of them is our relationship with the dying process that we cultivated through our daily experience in work, the teamwork and the self-care based on compassion and wisdom. To conclude, it seems that the usual organization of palliative care in Morocco was adaptable to the pandemic situation, but I wonder if we could maintain the main palliative care benchmarks, because I'm not sure that all patients with maximal complexity had home visits, and I'm not sure that all patients were able to access opioids, knowing that travel between cities was limited. So I think that proper palliative care doesn't only depend on the will and commitment of the palliative care teams, but above all on a political will for a true national palliative care plan and its corresponding budgets. Thank you.
Thank you very much, Asma. And thank you really for highlighting the last point. We saw also from our colleagues in Saudi Arabia that the high level political support is really important, just like you're highlighting. So colleagues, we have passed the time, but I think that is just an indication of how important and interesting these discussions are. We've reached our last speaker, Dr. Ibtihal Fadil, and we will zoom out a bit from the country perspective to a bit more regional perspective. Dr. Ibtihal is the chair of the NCD Alliance regional branch for the Eastern Mediterranean region. Thank you, Dr. Ibtihal, for joining us today. And I will put up your presentation here and just let me know. I should shift to the next slide. Over to you.
Thank you, Nassim. A greeting and good afternoon to everyone. I would like to take the opportunity to thank Sanad and WHO IMRO for inviting us to speak on behalf of the civil society group. So as Nasim saying, I'm the chair of the Eastern Mediterranean NCD Alliance, and I will be speaking on and presenting the voices of the civil society in relation to the work of palliative care. So just briefly, while the slide is on, we were talking about here the role of the civil society in area of palliative care. And civil society are always advocating for, they are a powerful advocate for the health, quality, equity, as well as the patient right and patient engagement. Eastern Mediterranean NCD Alliance is a non-profit, a network of organizations in the Eastern Mediterranean region. And we have over 35 organizations, or nearly is the 50 organizations now. They are working with in different area, and an area we are focusing on, one of it is the advocacy, access to care, raising awareness, training and exchange of knowledge, and accountability. As you know, civil society are very familiar with the work. Can I have the next slide, please? Civil society are very familiar in the area of community care and community level, and they are ground root sort of organization. So they are very interested in area of palliative care and fundraising and support patient and family during this time. As well as other activity which is related to training and so on. And on next slides, I will be alluding to many of the area which we civil society has covering. But please, I'm going to use this opportunity to pay tribute and honor to one of our pioneer in the region in civil and palliative care, Dr. Hassan Abbas, who passed away in 2012. Dr. Hassan Abbas, I think he is one of the first people who just inspired me in the area of palliative care. He was working in King Hussein Cancer Center. At that time, when we first started to have a palliative care movement in the region, we had a meeting in a global meeting with colleagues from WHO headquarters in Hammamat in Tunisia. It was a global meeting focusing on the area of palliative care, decent care for people who are terminally ill or serious illness, which we are facing now in COVID situation. And most of the room was people who have suffered HIV AIDS at that time. And I was, like looking into exactly from the perspective of cancer, how we can collaborate with other people who are affected by serious illness, and what does it mean palliative care. So we came into the prospect of palliative care not only in terminal, very severe and dying patient, it's the whole spectrum, which also most of the colleagues have explained. So we are honoring Dr. Hassan Abbas for his work in this area. Next slide, please. So if we see like the civil society, they were pioneer in the region, as far as the region in area of palliative care. And as some of you know, that I had worked in the area of, as a regional advisor for non-communicable disease in the regional office, WHO, and including the area of palliative care. At that time, I think when I started to work with civil society is just because of the work of the civil society in area of palliative care. I was very much inspired by the regional work of big organization, to name some of them, like King Hussein Cancer Center, non-profit, Lala Salma, the Saudi organization, Lebanon. All of them, I mean, have done a great job in the area of palliative care to initiate the work. They were strong advocate as a civil society voice and inspire and advocate with the government for establishing the services of palliative care, which was patchy and very limited at that time. So to start the work, I just want to give you some history. Most of you might be on this list familiar with it. I mean, no, the slide before, sorry. the slide before, we did in 2009 some mapping exercise and survey on what are the palliative care situation. And through that mapping, we discovered that most of the organization that survey, most of the organization working in palliative care in the region, they have a non-profit hat and they are from the civil society. And they are the people who are championing and leading the work of the palliative care in the region. And to put it in the context, whatever followed that by different, like consultation on how to start a palliative care in the region and do the regional training. It's also heavily presented and attended by the civil society in the region. The regional strategy on cancer control, which developed in 2009, has specified a big section for palliative care based on the consultation with the group of civil society in the region. And then the WHO started what we call it the regional training program. It's an annual training program happen in different places, but it's 2-3 years was in Kuwait because of the presence of the civil society there, the Cancer Federation, the Gulf Federation for Cancer Control, which is a group of civil society dealing with cancer, as well as the presence of a training center at that time. Also, during this training period, there is a lot of things coming out of it. I mean, although we were not in you could say in a proper shape at that time, because most of like you have people coming as experts who train the regional, and we have a regional expert, and there is a lot of people who are also willing to work in this area, but when you train them and when they go back to home, there is no environment to support them. There is no structure and governance in Ministry of Health or their organization to allow them to work in the area of palliative care. So there is a gap. I mean, some people who are going to go and they are very enthusiastic, but there is no environment for them to work. But also one of the positive upside of it, like creating the Regional Palliative Care Association. And to this, I should be acknowledging the work of Dr. Mohammed Bouchnaq and colleague from Saudi Arabia in the creating of this association, which grew up and, like created a lot of other work which is generated, like the Atlas is also done by Dr. Hiba, is based of the collaborator from this sort of association. And one of the things which we find also from the regional training, that we need to have a specific module for the training, like the one which is developed by EPIC on other big organization, and Oman took the lead voluntary. The Oman Cancer Association took the lead and developed 2 modules to train people on, similar to the module, to the global module. Next slide, please. So this is some shots from the regional training in Kuwait, and I said, like it created a good vibe and good spirit among these leader champion, because one of the main things in the palliative care area, as you all of experience, you need a big push and you need a support. So these are, I always call them champion, and they have published a lot. I mean, like there is Sheila Pine created, support them in developing or putting blogs on the European Society website. And we have Nahla. She is one of the people who have trained and also went back home and trained many people. And we have, you could see people from Egypt, Tunisia, Global, Jordan, Oman, Palestine, Sudan, all of them are part of this, and they go back and work as a civil society or even in the government. Next, please. I want, before the lesson, can you move to the other slide? So I said I will list some examples, and apology if I didn't mention some of the people here, but I tried to, as far I remember, I mean, the big organization in our region, civil society organization, currently working and keep working in this area. So like we have people from, I mean, King Hussein Cancer Center is always on the lead, and they have their own training program. They have also accreditation program and research in area of palliative care. We have the Saudi, they are pioneer. They are the first country which has accredited the program for palliative care. We have Morocco, Lala Salma Association, they have illustrated very impressive activity, and they support many activity like in the following slide I have a photo of people from the Gulf Federation. They are working with Lala Salma with the support of the Lala Salma as observer. Not to forget the Kuwait palliative care activity, and we have listened in the last webinar, and for the government as well as we have a lot of palliative care center created a regional momentum and regional platform for developing the activity. We have like the current host, we have the Sanad, and we have Balsam from Lebanon. They are a big civil society organization, and they are working on a volunteer as well as other activity. I mean, I'm not going to forget like the work in Oman, work in Iran and Pakistan. They have a lot of charitable organization and volunteer which working specifically on home-based and community-based services. Next slide, please. I mean, I need also to mention Egypt, Tunisia, the civil society of Tunisia. I met them, and they are also very impressive in working, and also in Sudan, as I mentioned. Apology if I missed some of them, but basically civil society in the region, they are leading the work of palliative care, and they will continue. This is, you know, example of inter-regional work. So this is a big organization like the Gulf Federation working with Lala Salma, supporting them because Lala Salma has long and existing experience in that area. They have the Beit al-Hayat, and as well as in Oman created a similar organization to support people in need. So what we have learned throughout the journey, we have learned to acknowledge the civil society work. The civil society is very strong advocate. Why? Especially for the palliative care. I mean, from my observation, and I think most of you agree, there is a very low commitment for the civil society. So you need to balance it in that degree. You have people who are committed and champion and in the civil society to push the government for that work. Most of the country in the region, when you you see that the people who are suffering, their work is not well recognized as a palliative care work. So to scale up the palliative care program, we need the strong advocacy of the civil society. We need the civil society to work in all areas of palliative care, which is capacity building, availability of medicine, which is most of you have mentioned. They need to work also on raising the awareness of health professional, political leader, and the community. Next slide, please. What are the challenges? I mean, I'm just mention about the work of the civil society, but definitely they are having a lot of challenges. One of the main challenges of the civil society work is poor funding. So they are very, very poorly funded, and they are depending on funding which is usually by donor agency or limited by some government, and this is a very limited type of funding to do their work. There is there is insufficient political commitment and priority given for area of palliative care in most of the country, and this is make the work of the civil society is harder and even strong effort needed. There is also civil society in Yemen, like they provide services, and they are limited in terms of their capacity and legislation with the medicine and availability of opioid and others for the people they are caring for. And the civil society lack the training and capacity among the staff who are providing, so they are depending on whoever volunteering to the services. At the same time, the awareness is very limited in the community. So that's limiting sometimes the work and push the civil society to work harder. Next slide. This is all beyond COVID or prior the COVID era. So in time of COVID, I mean, we surveyed or we asked people on how much they have collected information, how much the civil society have worked in area of palliative care. Unfortunately, it's very limited. And despite the seriousness of the illness, and we think there will be increased demand, or it is really, there is increased demand of palliative care, but the engagement of the civil society is very limited because of the social distancing, lockdown, travel restriction, lack of funding, medicine shortages, and also the staff as a volunteer and staff are not allowed because of the limited use of availability of the PPE. On the other side, we heard from Jordan and UAE last few weeks. They in a webinar they are providing services for terminally ill patients through video conferencing and telemedicine. The Eastern Mediterranean in general are regularly holding a webinar, and we are advocating for the right and engagement of the people living with NCD, including cancer. So we are trying to educate people more, professional and community, on this notion that people with NCD have to be engaged. And here in the photo I'm showing, this is the Bahrain Cancer Society distributing masks and gloves to people and the community. And we have also UAE Friend of Cancer Patient is one of the global pioneer in area of NCD advocacy, including cancer. They are also fundraising and advocating for cancer and cancer patient, whether children or adults. Next slide, please. Having said that, we have an opportunity. I think the opportunity for the civil society to grasp on and galvanize is there is a global commitment, which all of you have alluded to, with the World Health Resolution, and they are part of it. The civil society were part of this development of the resolution, with the UHC, with the creating of the civil society working group with the WHO. All this provide a platform for civil society to work on and push for and advocate for the palliative care. I think the presence of the current pandemic COVID raising the issue of the need of terminally and seriously ill people, and we have seen it even in developed country and industrialized, the well health system, they couldn't cope and provide a real quality palliative care to their patient. So COVID has enabled the development of also other things like the telemedicine and online consultation, which could be an opportunity to grasp for the palliative care people. Next slide, please. I'm just here showing you one of our colleagues in Kuwait who work in the palliative care. They are also a strong advocate. I heard, still remembering the story of this lady in the middle who said, one of her patients is having missing her coffee in the morning, and she always, you know, providing her coffee and make sure that she is sitting and chatting to her. So this is, you know, demonstrating the principle of palliative care by people who are working as a volunteer. She's a nutritionist and working as a volunteer with the civil society in Kuwait. So we are still counting, and we will be keeping counting on the big role of the civil society in advocating for palliative care. Last slide, please. To thank you, this is a photo who provided by, I just traced in my previous presentation and find this photo, is provided by my colleague from WHO previously. His mother is one of the cancer survivors. And he chose this photo for me for one of the presentation to demonstrate virtually and present virtually the cancer patient journey. Thank you for listening.
Thank you very much. And thank
Over
you for
to you. Sorry.
Thank you. Thanks really for highlighting the importance of the CSOs. And I really, it's really, I've seen it through the work with the regional network also, that it is the dedication and the engagement of the champions in the region that are the fuel for the palliative care agenda. And thanks, I also want to thank you for mentioning in your presentation the challenges with providing services for refugees and people living in camps. I think that's a very important part that we cannot forget also in these discussions. So, well, the time has come for the discussion, and I think we're going to open up for our fantastic speakers. Thank you so much to all of you for these great presentations. And I'm going to hand over to my colleague Slim for the moderation. I don't think you're going to lack anything when it comes to pushing forward this discussion, because there's so much to touch upon and to ask. I'll also tell you that we've gathered the questions in the chat. For the rest of you that are in the audience, please continue to comment and engage through the chat function. And with that, I'll just hand over to Slim. And thank you once again to all the speakers for the great presentations. Over to you, Slim.
Yeah, again, I mean, thank you very much for all the colleagues. It's really really warming for us, I mean, to see the enthusiasm of those pioneers, of people that are at the front line. I think many of you have commented that palliative care is sometimes quite a long journey. And I think for some of the countries' experiences, as we have seen, it's a decade as a journey to reinforce and position on the agenda this field of work for alleviating the suffering and supporting those families and the people that are in need. I think what I learned first is that the journey, there is no recipe, and to take maybe some of the quote of our colleague from an umbrella of framework that WHO provides, we need to build houses that take into consideration, I mean, the specificities of regions, of countries, and understanding. I think that contextual analysis is an important element. The second aspect, perhaps, of that journey, and some of the questions that I would try to distill rapidly, there are two main, I think, aspects. One is how much of this COVID pandemic has triggered our understanding about what was there that need to be strengthened and made more sustainable, and how much actually our system has been able to adapt itself to provide whether new services for people that were directly infected, but also to maintain essential services for those who were already our palliative care patients. So I think I will just split, there was two sets of questions. One question that I would perhaps address directly because it was related to WHO was from our colleague Reda, Professor Rizkala from Egypt, asking about, I mean, WHO role in the overall, I mean, COVID. As you know, I mean, many of our institutions as a health leading institution, we have working closely with member states, and all our offices from HQ to regional office to country level have been repurposed really to respond to the COVID response. So we have what we call, as part of our emergency response framework at WHO, reorganize ourselves under an incident management, like an emergency response team at all levels. And some of the regional office colleagues are following specifically on data on the number of cases, Others are more about the international health regulation and the ability, to control borders and all the infection and prevention measures, more on the capacity building on how we deal with and prevent, the spread of the infection. So we have different pillars and country support teams that directly follow each of the 22 countries in the region and worldwide on the COVID response. So we are really quite hands-on on supporting, including one aspect where we are involved ourselves is as part of the development of national strategic preparedness and response plan is the ability to maintain essential services that we have alluded to, including from palliative care. So this is in a nutshell, and if we want more development, we can do it offline about the role of WHO. And Reda, you were asking also, what about the plan of a second wave? I would say that at the moment, we are still maybe in a second peak of a first wave rather than a second wave per se. But what we see is that there is overall, a decline or a beginning of a decline, but many, countries are still, struggling with the number of response and the number of new cases and infection are still, increasing, especially when countries are now in a phase for economic reason, from, the seasonal and the touristic aspect, trying to also lessen a bit the public health measure and the lockdown. We see that in many countries, we have a resurgence of the cases. So I think we are following this very closely. I think we are not still in a phase where the vaccine is ready and will be distributed. As you mentioned, it's another issue. I think we are still following up on trying to reinstall some of the public health measures when we see an increase. I think it will be a cycle of reinstalling, moving and lifting those measures. I think we will not have an end per se, soon, but probably we will have to go back and forth on those public health measures. Now, some specific questions that were on the COVID that I learned also a lot on this presentation were related to what were the opportunities and what did we learn from the COVID response from a palliative care point of view. Some aspect that often were referred to is what we call adaptation of our service delivery models in particular, and many of you has referred to shifting from hospital-based to community or home-based with, like Asma has mentioned also, difficulty in the triage, the reprioritization to make sure that when we maintain those services, we avoid also the spread of infection. So making sure that both patient caregivers and providers are protected when providing those care. The other aspect is really the digital health solution, and we have seen with the example of Sami that sometimes it's even within the scope of a health system reform. So one of the questions for you, maybe whether Sami, Miriam, Asma, specifically on the service delivery model, how are you going to do to make these services sustainable? Is it something that is now learned and taken as something that in the next phase of maybe, we hope not, inshallah not, an outbreak similar to this one, we are better prepared? In other words, the service delivery model adaptation that you have learned, is it something that in your view would be sustained if another outbreak happened? And this is something that now we can maybe present. And what has been your contribution as providers or supporting the policy response in your countries to make sure that the palliative care aspect and what you have learned, like moving and shifting the service delivery model, is something that the Ministry of Health can integrate? Maybe we'll start with that question, and then we will open up to the wider question about how we transition from the COVID response to also better integration of palliative care. But any of you of the presenters who want to respond perhaps to this first question? Over.
If you allowed me, this is Dr. Sami. As we mentioned in Saudi Arabia, the palliative care service become an integral part in model of care and in healthcare system in Saudi. We did experience through the COVID-19, and we succeed to show the leaders that palliative care patient get benefit from virtual care and hotline service. For that, after presenting the achievement and the numbers, Usually the number is having the roles. They convince, and we have a plan now. In end of 2020, December, we need to converted our service to be virtual clinic, 30% of all palliative care clinics. Achievement and succeed is the key model for the leader to follow the norm and prepare for the future, whatever the future, even if there will be COVID or other viruses, or even will return to the normal practice before. Usually the virtual clinic is cost effective, helping patient and families. Online service is the key for the future. The caring of the patient, usually one physician can cover a lot of patients virtually. With help with the local people, they can serve better and better outcome for the patient. Thank you.
Thank you very much, Dr. Sami. And I think one point also that you referred to in your presentation is data talks. I think it was very interesting to see that you were able also to inform the policymakers about the drop of services, to be able to monitor and also to somehow document your successes. Any additional comment, Asma, Mariam, on that sustainability of the new service delivery model and what you have learned from this experience?
May I add something?
Please, Mariam.
Yes. Thank you for your question. We were planning to establish a palliative care clinic, a hospital-based palliative care clinic at first, according to our need assessment. But at the time of COVID-19, we found that home health care centers are the best options for us because of being high-risk patients. These healthcare providers who work in these home healthcare centers, they could go to homes and visit patients at their homes, which is a very safe place. And because we have the infrastructures of home care centers and we can develop these centers, because of that, I think that we are going to establish a home care palliative care system, I think, and we should change, at least in this time, we should change our model from clinic, hospital-based palliative care centers to home care centers. And I hope we can do this and shift our care from hospitals to the community. Thank you.
Mariam, perhaps as a follow-up, in Iran, you have, like many countries, emergency preparedness and response plan. Is this something that you might propose as a model for adaptation also for the emergency response? I mean, of course, I mean, we have an outbreak, but Iran is also, I mean, have floods like recently, earthquake. Is it something that you might consider as a model for adapting your emergency response plan?
Yes. Yes, as you said, we are a vulnerable, I think, country all around the world, and many crises and disasters, we affected by these disasters. Because of that, I think since many years ago, more than 10 years ago, we organized a crisis management center in the Ministry of Health. And fortunately, we trained many nurses as disaster nurses. So in response to this crisis, we asked our nurses who were trained in this regard, asked them to, manage the crisis according to what they learned. And they were our representatives in their University of Medical Sciences, and they are in touch with us at the Ministry of Health, and we transfer whatever we want to do through them. So I think our nurses, especially our nurses, did a good job in this regard.
Thank you, Mariam. Thank you very much for this informative response. Asma or the colleagues want to comment on this first element. Perhaps one aspect that I mentioned was the digital health technologies for palliative care. Is it something that you consider what are the requirements to make this, sustainable? In the case of Saudi Arabia, is within the reform, in a wider reform of the health system that consider virtual clinics and digital health solution. But in other countries, I don't know if you want to comment on the potential use and sustainability of digital health solution for palliative care, at least for some aspect that could be given by distance. Asma, perhaps?
Yes. In our case, for example, in Casablanca, and COVID-19, we did almost 500 phone calls amounts. And normally we do only between 100, 150 calls amount. And we try to do video calls, but the majority of our patients don't have a smartphone. So using digital technique in Morocco is very difficult. And in our case, the palliative care teams, we have the impression that we are swimming against the current, because we don't have a real support from the Ministry of Health or the government, because there is no a budget allocated to palliative care in Morocco. So we can't work only with our personal initiative in palliative care for training, for buying medicaments, sometimes for buying opioids for patients. So I think we can't. Palliative care in Morocco needs a real national plan and money for it.
Thank you. I think it's an important transition to from the COVID to the kind of more development issue and how to highlight perhaps primary palliative care as part of wider agenda. I mean, Ibtihal and other colleagues have referred, and Nassim at the beginning, about the universal health coverage agenda, the sustainable development goals. And we have seen, I think in particular with the illustration of the three first presenter and Michelle perhaps can intervene. There was a specific question also in the chat addressed to you, Michelle. The example of Lebanon have highlighted, I mean, the ingredient, we don't have necessarily a blueprint, but we see that there is a mix of frontliners, pioneers, people that are, I mean, the doers, like Ibtihal has mentioned, the society, and those who are able to start somewhere, responding to the needs, documenting what has been done. And the NGOs, I think in Lebanon was a very good example. But you also highlighted in your presentation, Michelle, aspect about political decision, legislation, regulation, adaptation that require also this progressively to be integrated in policy plans with a specific focus also on funding, like as Asma mentioned, if we don't have, I mean, a reimbursement or aspect about healthcare financing attached to it, it's very difficult, I mean, to maintain those services, let alone. So perhaps, Michelle, you mentioned, I mean, that urgency and the necessity as a human right also to respond to the needs of all patients. And one of the colleagues in the chat was asking, okay, it's good, I mean, in theory, but how do we expand? How do we scale up? And how do we build, I mean, that response in countries progressively? Over to you, Michelle, perhaps if, I don't know if you have a good connection now to respond to that.
Yeah. Yeah, thank you, Dr. Slama, for the question. Effectively, I think that the interaction between, palliative care and the pandemic of COVID-19 has changed so many things in our daily practice. You know that people in the hospitals where we have a big intensive care unit and reanimations, I mean, in the main hospitals, academic hospital, they are well equipped and they are well trained, to take care of patients in very critical situation. But in the case of COVID-19, the triage that might happen sometimes when you have a big number of patients arriving at the same time. It is a big issue and ethical dilemma for whom we have to give the priority of admission to intensive care unit, and how to convince some patients and their family, to accept to go to palliative care, knowing that this is a desperate situation, or these patient doesn't have any chance of making it when we put them in the intensive care unit. And that's why we work on this issue. We didn't have the situation yet, but I think now that with the second pandemic increase, we might arrive to such situation. And that's why we put the guidelines officially. They are now, accepted by the Ministry of Public Health, that we have to make some triage of patients, and of course the ethical aspect was treated by these guidelines, so that we have a good decision making of the medical people who are receiving and taking care of these patients. So that's why palliative care, if palliative care is there in these centers and it is a good unit and we have trained people, the situation was well handled by these people, and the transition was very easy to send these people to the palliative care unit. But the problem was in the hospitals where we don't have units, we don't have people trained for palliative care, we don't have a full team of palliative care. We felt that we have here something missing, and I think that's that all hospitals now, by a new policy that should be put by the ministry, that all hospitals receiving COVID-19 people should have a palliative care unit, so that the interaction and the collaboration between the intensive care unit people and the palliative care will be more easy, to apply in this hospital.
Thank you, Michel. Perhaps a follow-up discussion element or question for you and the colleagues that have, like Sami and Mariam, established also strong relationship with the Ministry of Health and have established, a committee and a network that is now actually quite effective, is for what would be the advice for countries that would follow, your step? We have seen that, as I mentioned, sometimes you start with pioneer, with people that are from NGOs and community driven, but at the same time, you need to link this into a formal institutionalized system where you have, funding, when you have political will. What would be, the take home message and your advice for countries that might be in the region willing to follow your path? Maybe Michel, Mariam, Sami in particular, and also Asma from Morocco. What are, we don't have necessarily a blueprint, but perhaps some of the guidance that you would give for those countries.
Yeah, I think that it is important that, as we did with the early, implementation of palliative care in the Middle Eastern countries and the EMRO countries, we had so many joint meetings and workshops and exchange between our countries. I have the pleasure I know all the people that are now on the screen, almost all of them. We've met at some time in Lebanon, in Kuwait, in Jordan, in Egypt, whatsoever, through the invitation of WHO or some other organization. And I think that now we can make the same thing, how we can interact during this COVID-19 pandemic, and palliative care people who are in these countries. I think that we should create this link between COVID-19 and palliative care, and not only letting it, to reanimation, to intensive care unit, to hospital care, and whatsoever. There is a part very important of home care for COVID-19 patients. And here, I think that palliative care has a big role, to follow these people at home. In the hospital, when a person, is found to be a hopeless case in the intensive care, where do you want him to go? The only place that he might be taken in charge is the palliative care team. So that's why the palliative care now, with the amendment of the COVID-19, I think that the role of palliative care is reinforced, and we should, give more importance to palliative care in the hospitals that are treating difficult cases or, life-threatening cases of COVID-19.
Thank you, Michel. Any additional comment from other colleagues on that aspect about, what are the steps to reinforce the national agenda using perhaps the opportunity of the COVID-19? Yes, Sami. If not, as I was asking on the chat, a question related to MRO and the data, whether we have data on people being treated for COVID-19 that require palliative care. We have actually a dashboard, but doesn't collect that information. And one of the challenges we are facing is really data to inform policy in the COVID response, that the data is shared by country. Some aspects are related to clinical case forms that are not necessarily very much completed, specifically on comorbidities and on outcome of management. So palliative care treatment, or the people in need of palliative care, it's often a data that the country has, but do not necessarily share, and is not collected in a systematic way. So unfortunately, most probably the network members might be in a better position than us to know in your respective countries, what kind of burden. But I think at a regional level, that data is not available, unfortunately.
Can I share this point? I think any change need to be planned. For any country who want to change to have a better future for palliative care implementation, they need to plan it well. One of the planning to have a pilot phase, taking certain population and move them from the hospital to the community with good quality of care, patient satisfaction survey, KPIs, restricted KPIs, and cost benefit. We did a similar study for 2 years in a row, and we achieved that we give a similar service between the hospital and the community with satisfaction 91% and cost-effective reduction 69%. 2/3 of budget from the hospital, we reduce it because we are pushing patient to the community. All the stakeholder and any Ministry of Health leader, they want to see the evidence. If you can show them that giving palliative care service, even in virtual care or in the community, it will reduce the cost for them, they will adapt it, and they are happy to implement it in the country. My advice, just pilot small scale, shows the number, put it in your stakeholder, show them, and scale up after that. Thank you.
Thank you, Sami. I see that Marie-Charlotte and Aza have your hand raised. Maybe, Aza, I don't know if it was the same question or another one. I'm activating your microphone.
Regarding our experience in the virtual clinic, we are doing like a survey to assess the efficacy and also satisfaction of the patient with this type of clinic. And also we are asking in the survey that if they would love to continue after COVID crisis gone, to continue with that clinic, is it as a routine or as a physical face-to-face clinic as add-on, or can both together? So we are waiting, we are collecting around 250 patients, and we'll see the response regarding the virtual clinic, and after that we can conclude what can we add for this type of service that get to us during the COVID-19. And we will publish this survey also to share with you.
Thank you, Azan. A very interesting survey that would inform us. Marie-Charlotte, any comment?
It's extremely important to learn while we are still in the middle of this crisis, because we are all in the middle of the crisis. And listening to you, I think very important message is because the palliative care is focused on the quality of life of patients and family, the fact that this has to be evaluated in the right way. And this is actually crossing the ethical issue of making complex decisions, and also the evaluation of the real benefit. I just wanted to highlight the situation of older adults, for example. In the middle of this crisis, in many countries, the real benefit of having older adults in ICU was not completely clear, and obviously producing a lot of ethical discussion with regard to interaction with the family, etc. So I think it's very important to learn from this experience, the good and bad experiences. The good experiences, what you mentioned, the fact that there is more and more effort to transfer the palliative care services as much as possible in the community. And I think it's particularly important for the most vulnerable people, and have also this in mind when we prepare in advance plans for these kind of patients. I think it's definitely a lesson for the longer term, not only for palliative care in the situation of this kind of crisis, but really to learn how to evaluate the real benefit of the care we provide to patients and to their family. So I think this is one very important aspect. And as you said, the other aspect is the capacity, even for people living in remote areas, to develop simple tools. I know it's often challenging, but to have this effort on new technologies to maintain the communication between patients, family, and caregivers. So I think it's definitely listening to you. I think it's two major points. We knew this, but this crisis is definitely insisting on these points has a priority in the way we strengthen palliative care.
Charlotte, perhaps as a follow-up question to you, when you say, better evaluating, what would be the role of WHO, how to do it, in practice in terms of next steps for those, frontliners that are already doing it, but, is there something that from our perspective we could share to support that?
Well, I think what we can try to do is to collect experiences. So this is, I think, a first step for networks such as this one to collect experiences in countries. Then, based on this, there is probably, and I would like to come back to what Michelle and others mentioned, some work to be done jointly with, for example, a National Ethics Committee or other structures that can help to prepare this the risk-benefit analysis and the tension between beneficence and non-beneficence. So probably this could be included in some kind of guidance document, or definitely in the training tools.
Thank you, and I will come back to that at the end. Perhaps there's a raised hand, and I'm cautious of the time. So there's a few questions in the chat that I still want to allude to. But Ibtihal, you have your hand, and Eric made a comment in the chat. I think it's important. So Ibtihal, and then Eric, and we'll then try to wrap up.
Yeah, I just have a comment regarding the role of WHO. I think, mentioning about what is the people on the ground doing in terms of government and civil society. I think the WHO have a great role, and I want to highlight the need for support of WHO because it has been mentioned by many colleagues on the ground, you know, like they are working hand paired on the, and with especially in country which has no strong political commitment, plus now the
see if we can reconnect. Perhaps Eric, meanwhile, if you want to make some remark.
Thanks, Salim. Well, a couple of thoughts that I had. One is, while I understand the importance of infection control and therefore use of mobile palliative care or virtual palliative care, in my experience taking care of a lot of COVID patients, the main physical symptom, at least, is dyspnea, and it often, or shortness of breath. And it often, it's a symptom that is often very sudden and very severe. And around the world, in my experience, many doctors don't understand that opioids, morphine or any opioid is very effective for relieving dyspnea, and how to use it to relieve dyspnea, beginning with very low doses and sometimes increasing aggressively to protect patients from suffering. So I think that could be a way, an important teaching point for throughout the region that could be disseminated, whether it's by EMRO or WHO or by NGOs. A second issue Marie-Charlotte mentioned at the beginning about goals of care and advanced care planning. Patients with advanced NCDs, whether it's advanced cancer or renal failure, heart failure, COPD, cirrhosis, or at high risk of death if they develop respiratory failure. And so one of the, I think, most effective interventions that we did here in my hospital in the US was to put palliative care, some of our palliative care specialist doctors in the emergency room to work with the emergency department and with families in helping to explain the prognosis and what palliative care is, because many people don't understand it, and identifying the goals of care that are most consistent with patients' values in that clinical situation. So that's a second thought. The final one is about what we call in the US crisis systems of care. So my question to you, Salim, and to Marie-Charlotte, could WHO or EMRO issue model crisis systems of care which provide recommendations on how to ethically allocate scarce resources, whether it's mechanical ventilation or remdesivir or the vaccine when it becomes available? Thanks.
Thank you, Eric. I will perhaps let Marie-Charlotte at one point respond. I've seen that, I don't know, Michelle, you raised your hand. I don't know if you wanted to have an additional comment. I'm just aware of the time, so Michelle, maybe quickly, if you want to take the floor again. I wanted also to give time to Farah and Lubna as our co-organizer, to have final words.
Yes, I have a last recommendation. COVID-19 pandemic is here to stay. Unfortunately, we will have it for at least 1 year more, with up and down, until we will have, universal vaccination and so on. So I think there is an opportunity now to promote, to develop palliative care in our area. And here I ask Marie-Charlotte, who was talking about the role of WHO. Maybe it is now time to send recommendation to our ministries of public health, stressing then that palliative care is an important adjuvant, a good tool that we can use in the fight against COVID-19 pandemic. Some Ministry of Public Health in our area are aware about having, machine, intubation and respirators, and how to have PPE and so on. They are not aware that palliative care is it's good support for the fight against COVID-19 pandemic.
Thank you, Michelle. And I think it's an important element. I just want to react on the role of WHO. I would leave perhaps some of the aspects of the question of Eric around. There's the element more that are related to the ethical consideration of resource allocation in crisis. We are in a region where half of our countries are in acute or chronic situation. Of course, this situation often happen. I think beyond, there is two aspects of your response, I think, Eric. One is service delivery model organization, is exactly what you have documented now, how we change, the way we provide services. The other aspect is the privatization, the triage, the allocation, the ethical consideration. I think both goes together. I think some part of the work has been covered across the organization around those ethical dimensions. It's less perhaps at the regional level. We should probably look at it more in depth, but I think from HQ, probably Marie-Charlotte can respond on that aspect. The second aspect that Ibtihal, was paying tribute to past people that have been really paving the way on this journey. I think our role was to build on what she did herself when in EMRO, and trying to provide a space first for countries to support each other, to document the work, to show, what are the challenges, the practices, and also to try to spread and amplify the advocacy for that policymakers, to better integrate as part of the universal coverage or the wider agenda palliative care. We will continue to do that. I think we can only do it with you, with your support, with your expertise, your knowledge, and your ability also to document better what you do in your respective country. So I think one of the role of WHO is really about convening, about documenting, and then producing also guidance documents that support countries with your support. I think this is where we continue to do the work. And I think it was one of the questions of Reda about how can we promote a pragmatical approach, is to document also. And this webinar is one example also that we can share together. We might discuss also with you colleagues and with Sanat having policy brief, or how we can maybe capture some of the recommendations from these two sets of webinars and maybe spread it across the network and beyond. So these are some of the concrete immediate steps that we can contribute to. Marie-Charlotte, I don't know if you want to add on the question specifically of the ethical dimension and how can WHO support. I think some of it are already included in the recent guidance that have been issued, but there is a kind of long past work on ethical consideration. I don't know if specifically on humanitarian settings we have something, Marie-Charlotte.
Yes, but very quickly on this point, because I think it's crucial. Our colleagues from the ethics team at headquarters have been working a lot over the past weeks to help countries in addressing ethical issues in the context of this crisis. Now, what could be done is, in very practical terms, I think the idea of having a policy brief can be a very good one. But I think it's always interesting to put together issues related to the ethical allocation of limited resources, starting with human resources and more technical aspects. So I think we can definitely take this suggestion and try to work on this. As you said, Slim, well, this is just one crisis within many others, particularly in your region. So we need to do this. Again, I would call again for an effort to gather information from countries. So this is really a bottom-up exercise. And if we can collect this experience and then try on the other side to provide a convincing argument and document for people making a decision in countries, we can definitely do this. I think what we learned in headquarters also is we can be quicker than usual in developing these kind of documents. We recently had an evaluation on the implementation of our work plans in headquarters. Well, we published, I think, 300 guidance documents in a few weeks, which is quite unusual. So we also have to learn ourselves from this challenging situation and be able to provide in a timely manner some documents that are useful for policymakers and people making decisions in countries. So I definitely take note of this, and we can work with our MRO colleagues on this kind of tool.
Thank you, Marie-Charlotte. And once again, I mean, we have now an established network in the region. Many of you are actively there. You are actively also responding to different surveys, including, I mean, the discussion on developing policy advocacy document, whether on opioid, on the overall integration. We have some group working on the curriculum for palliative care, primary care providers, on quality indicators. So there was a stream of work from this region and from this network that would benefit. And as we go, we can see how we can expand or continue. But I think this was the first set for us of deliverables. And this network is not closed, it's an open one. Many have also joining as they go. I mean, the interaction that we have with some of the NGOs and others that might to join in the future, they are most welcome. I think it's just a first step. There is, I think, one or two questions that I didn't cover. There was a specific, Marzi, I think Hassanpour, colleague from Iran, was asking specifically about some of the dimension about palliative care for pediatric in ICUs or neonatal care. I think it's very specific. I refer her also to Dr. Reda, in particular from our region, that has some experience in Egypt on palliative care and the palliative community. This is how I see also this network, is that when we have questions, she was asking about tools to use in ICUs for pediatric population. I think if there is within the network, some expertise in this field, share it among yourself, and please contact us if you want us to put you in relationship. But I think we have quite a lot to take from this two set of webinar. I just want to close perhaps this by giving the floor to Lubna and Farah, who has been extensively also involved with us. Thank also Nassim in particular, Rana from our team for the lot of work that has been put behind in organizing and preparing this with Sanad. But perhaps Lubna, if you want to give some concluding also remarks from your end, and thank you again, for taking this initiative of bringing the network together.
Thank you, Slim, for this great webinar and great moderation. Thank you for all the speakers for giving us the honor to work with all of you. I just wanted to conclude with this small, maybe take-home message. I believe it's time, maybe it's time for us to be more proactive in going towards primary team who take care of COVID patients. I don't think it's going to happen other ways that they will come to us. So this is the opportunity for us to approach them and be proactive. This is something also Mr. Claude reflected on yesterday in the experience in UK, that they have pushed for integrating palliative care into the response of the organization by attending meetings, being part of the associations and the task forces, and pushing to identify early on palliative care patients and work to support the primary teams. And this is also an opportunity to reflect on the new definition that the IHPC have made for palliative care that extends beyond the NCDs to go over communicable diseases. And it happened that we had a pandemic. So I think this is the right time to push towards such a thing, and us be proactive more with the COVID teams by themselves. And we're honored to have you all. And Lubna would like to conclude with a very short statement as well. Thank you very much for all your contribution and for the great work WHO has made also with us.
Thank you, Farah. Lubna?
Hi, Isleen. Thank you very much. Thank you, everyone. This was truly a pleasure. Just also one thing, I'm a believer in thematic coordination. It would be really interesting post this two-set webinar to look at different themes where certain countries have proven successful pilots in terms of telehealth maybe, or grief and support, or creating a network at the community level, or transiting from hospital-based palliative care to home-based. So I guess thematic coordination on success stories and key strengths in certain countries, where we can, as countries, NGOs and government, if possible, to support each other. So, for example, Lebanon can maybe support Palestine, or can support maybe Egypt, and vice versa, on certain themes where it becomes really concise and lessons can be learned on a vertical level. That would be something really interesting to happen. Thanks a lot.
Thank you, Lubna. This is really the spirit of creating this community of practice. Thank you very much for all. We will also try to, as much as possible, if you allow, contact you to get the presentation, perhaps on a website available, maybe with some summary of the main discussion and point of recommendation. Nassim, if you want to give the last final words. Otherwise, stay safe, all of you, and looking forward to continue the work in the region and beyond. Thank you very much.
Just a big thank you to everyone. Thank you for your patience and for staying with us. Thanks for these great discussions. If this was real life, we would enjoy dinner together. But unfortunately, we'll have to enjoy it separately. Thank you so much, everyone. Thanks to Sanat. Thank you to everyone that participated and stayed along. Have a good evening.